I guess I'll kick us off and welcome Dr. Winston Tilghman to High Rounds, our special hybrid session. So good morning to everyone online. So just by way of introduction, Dr. Tilghman is medical director for the HIV STD hepatitis branch of the County of San Diego Health and Human Services Agency. He's the STI controller for San Diego County, overseeing the operations of all STI clinics in the region with medical oversight on STI prevention, surveillance, and disease programs. Received his medical degree from University of North Carolina at Chapel Hill, and completed residency here at UCSD in internal medicine and fellowship in infectious diseases. He's board certified in both internal medicine and is also a volunteer clinical professor, assistant clinical professor in the Department of Medicine. Fun facts: Winston was a second-year resident, I believe, when I was a third-year resident when I was second-year resident when I rotated with medicine on the VA, and a third-year resident, I believe, when we did an elective together in Kenya. So we go way back. Yes. So thank you, Winston, for joining us, and welcome.
Thank you, Dr. Dice, for that nice introduction, and good morning, everyone. Thank you for being here, and thank you to the organizers for inviting me to present today. So I'm going to provide an update about sexually transmitted infections. I have no financial disclosures, and I will only discuss generic or chemical names of medications. However, some of the images included from CDC and other sources may include brand names. In those cases, those are the only options available in the United States, so I'm not endorsing a particular product. So there were kind of four main things I wanted to cover, and I'm going to go relatively quickly, although people please feel free to stop me at any point for any questions or comments. So I'm just going to cover a little bit of our 2022 epi data, talk a little bit about syphilis medication shortages and congenital syphilis, which is a major issue for us. I'm going to touch on gonococcal antimicrobial resistance, as well as some of the new agents that are in the pipeline that you may have seen in the news recently. But I really wanted to allow some time for a robust discussion about doxypep or STI prophylaxis using doxycycline. I know that Dr. Little covered some of the pivotal studies that were presented at CROI regarding doxypep. So this is just more sort of, I think, considering all of the issues with respect to doxypep, the data, and some of the concerns that have been raised and things that remain unknown. And I'd like to kind of get a sense of where everyone is in terms of their practice. And I think there's just a lot of interesting things we can talk about. And I think there's also an announcement at the end by Dr. Karras, so I'll try to allow about 5 minutes for that. If I can get the slide to advance. Sure. There we go. Okay. So starting with STI trends and disparities. So starting with chlamydia, you can see chlamydia is the condition for which we received the highest number of cases prior to COVID-19. It was the most commonly reported notifiable disease to CDC and locally. So still very common. In 2022, we had over 18,000 cases reported in the county. You can see that we had about a 20% drop off in our chlamydia cases from 2019 to 2020, most likely due to the effect of the COVID-19 pandemic on a routine screening for chlamydia, which is one of the primary ways that we identify chlamydia, since it's often asymptomatic. And we really haven't seen that pick up yet. So I'm not sure why that is. We'll have to see kind of what the next few years bring in terms of our chlamydia morbidity. But right now our cases are a bit lower than they were prior to COVID, but still very high. And our rate was about 550 cases per 100,000. Maybe I will use the computer to. The battery's running low. And so now with gonorrhea, we had close to 7,700 cases reported in the county in 2022. You can see a pretty progressive increase over the last couple of decades. And unlike chlamydia, we really didn't see a significant decrease in gonorrhea cases due to COVID-19 2020. Just a somewhat of a decrease during the sort of months where there were this stay-at-home orders and whatnot, but cases pretty much rose back to where we would have expected them to be based on previous year's morbidity later in the year. And that was pretty consistent with what was observed elsewhere in the United States. And we have seen increases in our gonorrhea case numbers since 2020. And then early syphilis, kind of similar to gonorrhea, no major effect of COVID-19 on our case finding and reporting. Maybe we're reaching a little bit of a plateau or regression to the mean in terms of our early syphilis morbidity. So we had very low case numbers, kind of going into the new millennium, but very progressive rises in cases over the last couple of decades.
Dr. Tilghman, there was a question in the chat saying, do we think this is because no longer mandatory reporting in San Diego?
For chlamydia? Or that's probably for chlamydia.
Yes, for chlamydia.
2019, Title 17, Section 2500 of the California Code of Regulations was changed so that chlamydia was only a lab notifiable condition, in contrast to gonorrhea, syphilis, and other conditions which are associated with a dual reporting mandate. So I don't think that should affect our numbers that much or to that degree. And I think the timing around COVID-19 is also kind of suggestive that there was some effect of the pandemic, either on testing or morbidity or both. But it's a good point. I mean, I think most labs are good about reporting to us, and a lot have, electronic feeds that feed directly into our surveillance system. But I can't totally rule out that may affect our cases somewhat, but I don't think it probably explains that degree of decrease that we observe. But good question. And this slide, okay, never trying to go to the next slide. Sorry, I don't know what is just going on here. And this slide just shows the breakdown of our early syphilis cases by stage. So primary and secondary represented in blue and green respectively. You can see the majority of, or over half of our early syphilis cases are early latent syphilis cases, which can be proven to have occurred within the last 12 months, but are not associated with signs or symptoms at the time of diagnosis. So that could mean, that we're doing a good job of testing people who are vulnerable to syphilis regularly and identifying infections before they become symptomatic, as well as hopefully, our public health interventions are also identifying people who have been exposed to syphilis or are vulnerable and getting them in for testing and identifying them. Yeah, next slide, please. That changed. Be more. Sorry. Oh, no.
Oh, I want you to shoot this.
Okay.
So he'll stop.
Yeah, there we go. Oh, next one. Okay. Oh, okay. So this slide just breaks down our chlamydia cases and rates by gender and age. You can see chlamydia tends to affect primarily people assigned female at birth, and unfortunately most of our data is fairly binary still. We're still working on that. So the genders represented here may not correspond to the gender identity of the cases. And so mostly a younger age group and higher rates among people assigned female at birth than people assigned male at birth. Next slide, please. In contrast, we see higher rates of gonorrhea among people assigned male at birth, and you can see there's a slightly older sort of age distribution. Next slide, please. And then for our early syphilis cases and rates, you can see, we are still predominantly, seeing syphilis cases among, people assigned male at birth. And the age distribution tends to be fairly broad, anywhere from the 20s to 40s. We are seeing concerning increases in syphilis rates among people assigned female at birth. And I'll talk a little bit more about that in a few slides. Next slide, please. Okay, and so I'm just showing the early syphilis cases and rates by gender and race ethnicity, because syphilis really is the condition that we work the most closely in terms of our public health investigations. We're interviewing most of these cases, not all, and we're verifying treatment and staging, for everyone. So our race ethnicity data is most complete for our syphilis cases, particularly for chlamydia, which, as I mentioned previously, is only lab reportable now. We have over half of our cases are missing race ethnicity data. But you can see syphilis, as with other STIs, disproportionately affects people of color, particularly our Black and African American residents, and that's true for people assigned male and female at birth. Also, there's a higher rates among Hispanic and Latinx individuals than white or Caucasian individuals. The rates among Native American and Alaskan natives are quite high, but those are based on very few case numbers, so those should be interpreted with caution. Next slide, please. And this slide just shows the sort of trends over the last 6 years or so in terms of early syphilis rates by race and ethnicity. And you can see, again, significant disparities, and we actually have seen somewhat of an increase in our rate among our Black and African American residents, and this, people of all genders, compared to other groups where we see either sort of stable rates or even a slight decrease. Next slide, please. Syphilis and other STIs also disproportionately affect gay, bisexual, and other cis men who have sex with men. And this slide shows the proportion of our early syphilis cases who are MSM over time, represented in the blue. So around 60% or so of our early syphilis cases are MSM. The next slide, please. This slide is sort of a slide that we started adding a couple of years ago, really looking at the proportion of our pharyngeal and rectal gonorrhea and chlamydia cases that were and were not associated with a positive urogenital test. So really trying to get a sense of how common isolated extragenital infection is, which indicates that if screening were limited to the urogenital site, the infection would be missed. And you can see, particularly among people assigned male at birth and for gonorrhea, the majority of our cases of extragenital infection are not associated with a positive urogenital test. Now, and this is consistent with some research studies that have been published. One of the limitations of this is that negative results are not reported to public health, so we cannot say that testing was done and was negative, or if testing was just not done. But in general, urogenital screening rates tend to be higher than extragenital screening rates. So I think most of these cases probably were screened with a urine test or a vaginal swab, but I can't confirm that. Next slide, please. And this slide shows the percentage of our early syphilis cases who are MSM who are also living with HIV, and that's just over 50%. So for people who are diagnosed with early syphilis and are either HIV negative or do not know their status, early syphilis diagnosis is really an indication for HIV PrEP if they're not living with HIV. So it's really important to make sure that we're linking people to appropriate HIV related services. Next slide, please. And just to end sort of the data section, This slide shows our congenital syphilis cases and rates from 2013 to 2022. We had 35 cases of congenital syphilis reported in the county in 2022. From a surveillance perspective, congenital syphilis means any infant that's born to a birthing parent that had either untreated syphilis or inadequately treated syphilis at the time of delivery. And we define adequate treatment based on the medication that's given, whether it's CDC recommended treatment, and if it's given initiated at least 30 days prior to delivery. So that's regardless of any signs or symptoms in the newborn or the infant. And in the green here, you can see the number of stillbirths that we've had during this time period. So we've had about 12 stillbirths, including 2 in 2022 due to syphilis. So one case of congenital syphilis is a sentinel public health event, and of course 35 is way too many. And as I'll show in a little bit, our cases are relatively low compared to other jurisdictions and sort of the nation as a whole. But still, this is a great concern and is really a call to action for all of us. Next slide, please. And this slide shows cases of early syphilis among persons of childbearing age, which we define as 15 to 49 years. And you can see increases in this age group, which corresponds to our increases in congenital syphilis. Next slide, please. So now I'm going to just touch on a couple of additional things as far as syphilis goes. Next slide, please. And I apologize if this isn't very visible because of the small font on the right, but I just wanted to highlight a publication from CDC highlighting missed opportunities for the prevention of congenital syphilis. This was based on 2022 national surveillance data. In 2022, there were a total of 3,761 congenital syphilis cases. This included about 7% that were either stillbirths or infant deaths. So out of these 3,700 plus cases, just under 2/3 of cases received timely testing during pregnancy, defined as at least 30 days prior to delivery. And then kind of breaking it down even further, only 7% received both timely testing and timely treatment. And then in the blue areas, you can see some of the reasons why those criteria weren't met. So with respect to testing, either non-timely or no documented testing was present for over 1/3 of cases, and late identification of seroconversion occurred in a small percentage. And then most of the people who were appropriately tested but were not treated in a timely and adequate fashion had inadequate treatment documented. And then there was over 10% for whom there was no documented treatment. Very small percentage of people who, despite clinical evidence, who had clinical evidence of congenital syphilis despite therapy or treatment of the birthing parent. Not quite sure why this was, possibly very late infection, but CDC didn't really elaborate too much on that, but published congenital syphilis prevention rates with long-acting penicillin G benzathine at about 98%, so it's highly effective. Next slide, please. I also wanted to highlight syphilis screening guidelines in pregnancy, because depending on which guidelines you're looking at, there's a little bit of variations. So starting with sort of the lightest to the, or in terms of frequency, the lowest frequency to the highest frequency. In the 2021 STI treatment guidelines, CDC recommends screening for syphilis during the first prenatal care visit or upon identification of pregnancy. And screening can also be considered during the 3rd trimester and at delivery if a pregnant person is from a community with high rates of syphilis or is considered at individual risk. The CDPH guidelines, or California Department of Public Health guidelines, which were released in 2020, recommend a minimum of 2 syphilis tests during pregnancy for all pregnant people in California, regardless of any risk factors, including at the first prenatal care visit or upon identification of pregnancy. And again, during the third trimester, ideally at 28 to 32 weeks gestation. A third screen is recommended at delivery unless the person has had a documented negative third trimester screen and is considered at low risk of syphilis acquisition during pregnancy. And interestingly, recently, just in the last 3 or 4 weeks, the American College of Obstetricians and Gynecologists, or ACOG, has recommended 3 syphilis screening tests across the board for anyone who's pregnant and recommend against any sort of risk assessment. And I think this is based on the rationale provided, that they're concerned about the increasing rates of congenital syphilis, as I believe all of us are, and they also highlighted a lot of the health inequities associated with congenital syphilis. So I've referenced the practice bulletin if you're interested in taking a look. CDPH is kind of considering ACOG's new position. I'm not sure where they're going to land on that, but more to come.
A few questions in the chat.
Sure.
Do you have data on appropriate birthing parent treatment for syphilis and negative syphilis testing in baby in San Diego? That's from Jill Blumenfeld. Jill, do you get the question? Jill, maybe unmute yourself.
I'm not sure if I did.
I think you presented it from the CDC, but basically how effective is therapy when you treat the maternal, when you treat the birthing parent for syphilis, how effective is it in preventing congenital syphilis?
Yeah.
I think you just showed it in the US. I'm curious if we have data in San Diego and California.
No, we have not done any analysis here in San Diego in terms of the efficacy of the long-acting, injectable benzathine penicillin G, but definitely an interesting question. Yeah, so we really just kind of have the success rates, in published studies and some of the national data. Yeah, but we haven't done a deep dive, but a lot of our cases are associated with, no prenatal care or late access to prenatal care. That's sort of the most common thing that we see, as well as what's observed in the state level. And a lot of people, are not treated basically until they come in for delivery. That might be the first time that syphilis is even identified for those folks. But happy to,
Got it.
provide any data that might be helpful. Yeah, but I don't have that at my fingertips.
So there's 2 more, and I'll hold those till the end. I know.
Sure.
We'll get to them.
Okay. Okay, I think that's it for this. Next slide, please. And of course, many of you are probably very aware of the medication shortages that we're facing in the STI field, specifically with respect to injectable long-acting benzathine penicillin G. And that was first announced by the FDA back in April. Initially, the resumption of normal supply was anticipated for just within a couple of months, but of course that's been pushed back several times, and currently normal supply are projected for the end of this year. So we'll see about that, and that applies to both the 1.2 million unit and 2.4 million unit doses. Next slide, please. So, CDC, CDPH, and our health department have provided some interim guidance for rationing, if you will, of this medication, since it is the only option for treatment of syphilis in pregnancy, and is also often used for treatment of infants who are exposed to syphilis in utero. So we do recommend monitoring inventory of long-acting benzathine penicillin G, notifying us, of course, if there are any issues that arise, and consider ordering benzyl penicillin, which I'll discuss in the next slide. Prioritizing use of long-acting benzathine penicillin G, or the sort of alternative that is now available for pregnant people who require syphilis treatment, for infants exposed in utero to syphilis who require treatment, and for people with a contraindication to doxycycline, such as Stevens-Johnson syndrome, hemolytic anemia, anaphylaxis, etc. and using alternative treatment for other non-pregnant people who have or have been exposed to syphilis, and that primarily is doxycycline, 100 milligrams twice daily for 14 days for early syphilis and for 28 days for late syphilis or syphilis of unknown duration. Next slide. I think this is less of an issue than it may have been earlier during this shortage, but CDPH did provide some specific guidance regarding use of both long-acting injectable benzathine penicillin G and doxycycline, specifically in situations where people may have received 1 or 2 doses of penicillin G and then are being transitioned to doxycycline to mitigate the shortage. And so they essentially recommended against mixing and matching PenG and doxycycline to complete the appropriate duration of treatment. So an example of this would be prescribing 3 weeks of doxycycline 1 week after a single penicillin injection, or prescribing 2 weeks of doxy following 2 weekly injections. They recommend, if the plan is to switch someone from PenG to doxycycline, to provide a complete 28-day course of doxycycline, which I mean, we know that there can be some challenges in terms of adherence with that long of a course. And if a non-recommended regimen is used, they recommend more frequent serologic monitoring and follow-up about every 3 months. Next slide. They also provided some recommendations regarding ceftriaxone, for which limited data are available to suggest that a 10-day course of ceftriaxone 1 gram IV intravenously or intramuscularly daily is not inferior to 2 weekly doses of long-acting benzathine penicillin G, which we know 1 dose is sufficient for treatment of early syphilis. There are no data available to support shorter treatment courses of ceftriaxone. Ceftriaxone is also an alternative treatment for neurosyphilis, and that is in the CDC guidelines. Currently, there's no shortage of aqueous crystalline penicillin G, fortunately, but things can always change. And if ceftriaxone will be used, the duration would really depend on the dose that's given. So shorter, more like 10 days for 2 grams, and 2 weeks for 1 gram. Next slide, please. So a few months ago, the FDA announced that it was allowing the temporary importation of benzathine benzoyl penicillin from France. So this has been determined to be equivalent to long-acting benzathine penicillin G for syphilis treatment, same dosage, stage-specific dosing recommendations. And so, so this is really meant to help ensure adequate supply of injectable penicillin for treatment of syphilis in pregnancy. So the recommendations, in terms of prioritization of injectable penicillin still apply. It does not negate those. But for centers that are encountering supply issues with long-acting benzathine penicillin G, gosh, that's a mouthful. This is an option, at least for now. Next slide, please. But there are some key differences between these injectable forms of penicillin G. So by long-acting benzathine penicillin G is supplied as pre-filled syringes. And these are all the only 2 injectable forms of penicillin available for syphilis treatment in the US, by the way. So the one we traditionally use, it comes as pre-filled syringes, whereas the imported penicillin is actually a powder for reconstitution. So you have to then add the diluent. And the benzathine benzoyl penicillin from France contains soy phospholipids, so you wouldn't want to give it to someone who has a soybean allergy. It's typically a higher volume that you're administering to patients. Both are given via deep intramuscular injection, but the imported penicillin, does have a volume of either 5 milliliters or 7 milliliters for 1.2 and 2.4 million unit doses, respectively. So there are, kind of great resources out there that highlight the key differences between these medications. So if you are considering using the imported form of penicillin, definitely would recommend reviewing those. Next slide, please. Might be coming to the first poll question.
But before you get, well, you said if we're considering using it, I'm assuming it would have to come from either the state or the county. So I would think that it would be your supply of some kind. So I was just about to ask Shannon, do we have any? But I think you're probably the first person to ask, like, has it been imported into California as far as you're aware?
Well, I don't know. That was
Okay.
actually gonna be one of my
Okay.
polling questions, because I don't know, and we
Okay.
haven't really received any notification
That's what
of
Okay.
any supply issues, so I'm kind of curious as to what's
And
happening.
Shannon just asked a
Yeah,
question,
in
so
the
we'll.
community. So yeah, I think, but yeah, I think to answer your question, it doesn't, we would love to know about it if you're having any challenges. Getting injectable penicillin for syphilis treatment, so that we could potentially help. But you could actually order the imported penicillin. Yeah, you don't have, it's not controlled by the health department.
Okay,
So it looks like people have already started answering the first question in terms of has your practice or institution experienced any supply issues for long-acting benzathine penicillin G? So it does look like actually, give folks a couple more seconds to answer. So it looks like at least a third of you have experienced some sort of issue. So definitely would love to talk more with you about that and see how we can maybe collaborate to make sure that you're not running into any issues. And hopefully, if you have a pregnant person who requires syphilis treatment, you're still able to do that. And if not, please definitely contact me.
I may be speaking for out of turn, but I would assume some people who are answering yes, in that it's like we have to be thoughtful about who we're giving it to,
Right,
but I don't think anyone's having trouble.
like
giving
acute
it-
shortages.
Right, we're not like,
Okay.
there's none, and it's more like, oh, well, we know this person's adherence isn't great, but if our
Right.
only, like, we'll do the doxycycline because we don't want there to be any issue, so that may be part of it. And
Right.
please speak up if I'm,
Yeah, please
if
feel
the
free.
people
yeah,
who
to
said
type.
yes.
Yeah,
it's
we'd
more
love to
than
know
that.
more about that, yeah. And there is a question, I think, about rationing strategies. I
Right.
think that's maybe the third
Well,
poll question. So
Yeah, and Shannon did say, are you able to share the pathway to obtaining the French supply with us? So I'm
yes.
sure there'll be some questions about
Yeah,
that.
I'm happy to do that. So maybe remind me
I-
or give me
well-
a to-do list so I don't forget. Now the second poll question is, has anyone used the imported penicillin or ordered it? Sounds like maybe people still aren't familiar with how to order it. So I'm guessing this is gonna be no for most folks, but again, kind of curious. We have not ordered any of it. We have managed to sort of maintain our long-acting benzathine penicillin G injectable supply. Okay, so it looks like, yeah, and that's kind of what I expected, but just wanted to double check.
I ended it because it was clear the trend.
Next slide, please. And this is, I think, the last of the poll questions for this section. Are there any restrictions on use of long-acting benzathine penicillin G at your practice or institution? Though this might not capture, all of the ways that people may be managing this situation, but maybe pick the one that's closest to what you're doing.
Fortunately, no one's saying what you're doing.
Oh, we can share the poll at the end.
Yeah.
Yeah. Oh, no one can see it at all. Oh, that's right. Only only we can. see
Oh,
it.
okay, I'm sorry, I thought it
No,
was being
that's-
projected.
I
to
can
the
clear it
audience.
after.
Oh, okay. So. Okay, so it looks like about 9% are reserving it only for pregnant people or neonates, infants who require syphilis treatment. About 14% for people with contraindication to doxycycline. About a third to both of those people who meet both of those criteria, or both of those groups, I would say. There are about 9% who are not having to restrict use. So that's great if your supply is adequate and you haven't run into any issues. And then a few for whom it may not be applicable or who don't know.
And since you can't see this, I think this is the important point, and I think you were getting at that, Nettie said restrictions implies a hard stop. We've given guidance and asked people to reserve, but there's no hard stop, and I think that's probably similar across institutions.
Right, yeah, and we're also handling it on a case by case basis. We have our sort of general guidelines that we're following, the ones we put out, but yeah.
There were two leftover questions about the
Okay.
congenital syphilis. Do you want to take those now or the end?
Maybe towards the end. Yeah, I have a few things I want to allow, some time for some doxy-pep discussion. But yeah, I do want to, we'll make sure that I get to those. So just a few updates about gonorrhea. Next slide, please. So drug resistant Neisseria gonorrhea is a major public health concern. And there have been warning signs in recent years, that ceftriaxone, which is still very effective against gonorrhea, especially here in the United States, may be losing some efficacy. We may be losing some efficacy. There was a cluster of cases in Hawaii reported in 2016 that had high levels of azithromycin resistance and decreased susceptibility to ceftriaxone. All of those patients responded to standard therapy at the time. Also, there's a mosaic PIN-A60 allele that's been associated with reduced susceptibility to cephalosporins and ceftriaxone treatment failures in places like Australia and UK. Fortunately, we haven't had any ceftriaxone treatment failures due to resistance here in the US, but of course, that is always a looming threat. So there was one isolate identified in Las Vegas through routine surveillance. Patient responded to treatment, and then there were two isolates in Massachusetts, and one of which had decreased susceptibility to ceftriaxone, cefixime, and azithromycin, as well as resistance to tetracycline, ciprofloxacin, and penicillin. So pretty much all of the antibiotics that we usually test for susceptibility. Fortunately, both of those patients responded to treatment at the time. And also recently, findings from a WHO surveillance program in Cambodia were reported with 15.4% resistance to ceftriaxone, 43% resistance to cefixime when oral third generation cephalosporin, and then a small percentage, about 6%, had resistance to the cephalosporins as well as azithromycin and ciprofloxacin. And resistant gonococcus in Asia has been implicated in some of the treatment failures reported in places like Australia. So definitely important to keep an eye on this. Next slide, please. Yeah, so this is just a reminder of the current gonorrhea treatment guidelines. Single dose of ceftriaxone 500 milligrams intramuscularly for patients weighing less than 150 kilograms or 330 pounds, 1 gram for people who weigh more than or 150 kilograms or more. Dual therapy is no longer recommended if chlamydia has been ruled out or is not a concern. But doxycycline is preferred over azithromycin for chlamydia coverage, except during pregnancy. There is the alternative treatment regimen that can be used for non-pharyngeal infections. It can be used for pharyngeal infections, but there's data from, I believe it's Seattle, that indicate that the efficacy is quite poor for eradication of pharyngeal infection. But gentamicin 240 milligrams intramuscularly plus high doses of azithromycin. Sorry, that should be 2 grams. Typo on my part, I will correct that before the slides go out. And according to CDC, there's no alternative for pharyngeal gonorrhea. Expert consultation is recommended. Not very helpful.
There's the recommendation.
Right.
Actually,
Yeah,
experts who have no.
you could do. I mean, I think what they're getting at is most people who report a penicillin allergy, which is what I think results in with, cephalosporins being withheld from patients. Most people with penicillin allergy that reported penicillin allergy actually can safely receive third generation cephalosporins. There's a very low rate of cross-reactivity, and a lot of the sort of childhood allergies and other reported allergies are actually not necessarily contraindications to ceftriaxone. So I think they're getting at, like, really, you need to take a thorough history, really dig into that allergy, and give ceftriaxone if you can. And then, of course, I think the test of cure at 7 to 14 days with NAT, nucleic acid amplification testing or culture. I think we all probably have our opinions about that, and all have had some experience with it. A lot of retesting, sometimes retreatment, but that's sort of what the recommendation is for now. Not sure if that will change in future guidelines. Next slide, please. So I just wanted to highlight a couple of new antibiotics that are in the pipeline for gonorrhea treatment. So there's zoliflodacin, which is a novel spiropyrimidine trione antibiotic. It acts on the sort of topoisomerase pathway, and it received fast track designation by the FDA for development as an anti-gonococcal agent.
It's been 6 years. I
Yeah.
don't understand that. Do you understand, like, fast track, this guidance came out, or this study came
Yeah,
out
I
in
guess that
2018.
implies that the usual track for FDA approval was like 2 decades. Because, yeah, so these are data from a phase 2 study, showing, good high efficacy of zoliflodacin at both 2 gram and 3 gram doses for urogenital gonorrhea as well as rectal gonorrhea, although there were very few rectal infections included. But the efficacy was not as good for pharyngeal infection, again, based on a small sample size, and was a bit better with the 3 gram dose. So that is what is being used in the phase 3 study, which, next slide, please. I've seen a press release for the phase 3 study, but I haven't seen any publications so far, or presentations at any trials others have. Would love to get those, but basically the bottom line is that they enrolled about 900 patients in 5 different countries, including the US, and randomized them to receive a single oral suspension 3 gram dose of zoliflodacin or standard of care, which at the time of the study included ceftriaxone 500 milligrams IM plus azithromycin 1 gram, and that was really to cover both European and US guidelines at the time. It did meet, zoliflodacin did meet specified non-inferiority criteria compared to standard of care. So that's kind of all I know at this point.
That's all that's out here.
Yeah, I think that's all that's out, but yeah, very encouraging. So at least for urogenital infections, this may have some promise, and hopefully we'll have some more data regarding extragenital infections, particularly pharyngeal infections, which we know are harder to treat. Next slide, please. There's also another antibiotic called Hepatitis, and this is a novel triazacinapthalene, type 2 topoisomerase inhibitor. Yeah, I had to practice that. So it acts at 2 different points, or on 2 different genes. And so in theory, 1 single mutation will not be enough to confer resistance to hepatitis. And so it did show promise in a phase 2 randomized open label dose ranging study of a single dose. They looked at a couple of different doses, 1,500 milligrams and 3,000 milligrams, compared to sort of standard of care. Overall, high efficacy rates, but there were 3 urogenital treatment failures. They all had very high MICs, or the highest observed MICs to hepatitis, and a gene mutation that's known to affect hepatitis binding. So maybe a single mutation is enough to knock it out. There were no treatment limiting adverse events for either dose. And there were a very, very small number of extragenital infections included. in the study. Next slide, please. And I think at a current conference in Barcelona right now, they're presenting these phase 3 trial data, the Eagle-1 study, which is a randomized open label multi-center trial, enrolling participants primarily with urogenital gonorrhea and positive Neisseria gonorrhea on urogenital sample. 1-to-1 randomization to either to 2 3-gram doses of oral gepotidacin spaced 10 to 12 hours apart versus ceftriaxone 500 milligrams IM. And this also met non-inferiority criteria for treatment of urogenital gonorrhea specifically compared to ceftriaxone-based therapy. They did report higher rates of adverse events in the gepotidacin arm, including drug-related adverse events. I haven't seen any detail about that and what those events were, how severe they were, etc. Imagine more may be coming very shortly for that. And again, we need more data for extragenital infections, but at least something. We have something that may help us and give us more options, particularly for people who just have urogenital infection. Next slide, please. And so now really wanted to just complete, and I know we're getting close to time, so I'm going to kind of go quickly through some of the background here. I think a lot of it you've already heard. So, doxycycline, STI post-exposure prophylaxis, DoxyPEP. Again, I know Dr. Little covered a lot of the latest data from the 2 sort of landmark studies among men who have sex with men and trans women, including the DoxyPEP study from San Francisco and Seattle, which included both MSM and trans women with who are either living with HIV or were on HIV PrEP. So there were kind of 2 different groups randomized in a 2-to-1 fashion to receive DoxyPEP or standard of care. Overall, 65% reduction in STI incidence per quarter. In the DoxyPEP arm, you can see around 80% reduction, regardless of HIV status, for chlamydia and syphilis, and about 50% reduction for gonorrhea, which I think took a lot of people by surprise, given relatively high rates of tetracycline resistance among gonococcal isolates. And then there was also the DoxyVac study in France, which included over 500 MSM on HIV PrEP enrolled in a PrEP study. And in both of these studies, participants had to have had an STI diagnosis within the last 12 months to be eligible. So for DoxyVac, as Dr. Little covered in her talk, this was a 2x2 factorial randomized open label trial. First randomizing people to receive DoxyPEP or no PEP, and then in those groups, a 1-to-1 randomization to either receive a group B meningococcal vaccine or not to receive it. At least I'm going to focus on the DoxyPEP results. So there was an 83% reduction in the first episode of chlamydia or syphilis, about a 33% reduction in the first episode of gonorrhea in the final analysis. So a bit lower than the sort of roughly 50% reduction in gonorrhea observed during the interim analysis. And France has a very high background rate of tetracycline resistant gonorrhea. I think it's like over 90%. So next slide, please. There was also the DoxyPEP open label extension. So for the DoxyPEP trial in Seattle and San Francisco, participants had the option to who were randomized to the standard of care arm in the randomized portion of the trial were given the option to switch to DoxyPEP for the remainder of the 12-month follow-up period. DoxyPEP remained highly efficacious as far as reduction in chlamydia and syphilis goes. Not as much for gonorrhea, I think, as was initially observed. Interestingly, the number of sex partners reported by people in the open label extension group were significantly higher than in the as randomized portion, particularly in those who had been in the standard of care group and then switched over to DoxyPEP. Uptake was quite good, and coverage of condomless sex acts by DoxyPEP was also very good. Next slide, please. And then this slide shows some sort of real world ecological data, if you will, from San Francisco, really comparing cases of chlamydia and early syphilis reported to the public health department there before and after a city and county-wide recommendation for doxypep for the study population and consideration of doxypep for other MSM trans women, I believe trans men as well, they mentioned. And so that was in roughly October of 2022 when that recommendation came out. This gray line here kind of represents what they projected the reported case number would be if nothing changed in terms of the way practices in the community. And you can see there were significant decreases in both chlamydia and early syphilis, around a 50% decline among MSM and trans women in San Francisco following the citywide recommendation and adoption of doxypep. There was no significant change for gonorrhea in contrast to the research setting. Next slide, please. I just wanted to talk a little bit about safety and tolerability.
Oh, good morning. How are you?
Hi.
Good, good.
Smeller.
The best. Good morning.
So just going through, some safety and tolerability issues. Obviously, doxycycline can have some side effects: nausea, vomiting, pseudotumor cerebri, and cause piloesophagitis, which often that can be mitigated just by taking it properly. So in the two sort of landmark studies for at least for MSM and trans women, there were no serious adverse events attributed to doxycycline in the as randomized part of the doxypep study. And overall acceptability was very high among that study population. In the open label extension, there were 2 discontinuations of doxypep, one due to participant preference and another due to side effects, which was a fixed drug eruption. There were no grade 3 or 4 adverse events. Next slide, please. And then in the doxyvac study, interestingly, also a fixed drug eruption was the one drug-related severe adverse event, but otherwise no grade 3 or 4 adverse events or treatment discontinuation due to adverse events. Next slide, please. Obviously, antimicrobial resistance is a major concern with doxypep. For gonorrhea, I think it goes without saying that that's a major concern. So we have limited data so far from these studies. In this doxypep study, there was in the setting of a 50% reduction of gonorrhea with doxypep, tetracycline resistance was present in 4 baseline GC isolates and then 6 incident GC isolates in the doxypep arm, so higher than the standard of care arm, for which there were 2 incident GC isolates, suggesting that so there was a higher percentage in the doxypep arm of gonococcal isolates with resistance or high level resistance to tetracyclines. Their interpretation, this investigators' interpretation, was that doxypep is likely less effective against tetracycline resistant strains, which makes some sense, but again, the small numbers are a limitation. They also reported on Staph aureus, for which doxycycline can be used for treatment. So doxypep was associated with a 14% absolute reduction in Staph aureus colonization and an 8% absolute increase in tetracycline or doxycycline resistance compared to baseline. With respect to MRSA, overall prevalence of methicillin-resistant Staph aureus was low, around 6%, and doxy-resistant MRSA was actually unchanged with doxypep use. And then for non-pathogenic Neisseria species that could sometimes acquire genetic material from Neisseria gonorrhea, nearly 2/3 of isolates already had pre-existing doxycycline resistance, and there was no significant change with doxypep use. But again, these are small numbers, pretty limited data. Next slide, please.
We're at 5 minutes.
Okay. And then, for the doxyvac study, there was all of the baseline gonococcal infections for which they had culture data. There was not all the patients in either of these studies had cultures, or specimens collected for culture, and the yield was low because there were a lot of extragenital infections. It was 100% resistance for the baseline isolates, and higher rates of high-level resistance for the doxy-PEP arm. Next slide, please. Other antimicrobial resistance concerns. So for syphilis, there has been no case of documented doxycycline resistance, resistant treponema pallidum. And then as mentioned previously, or I think it's maybe Dr. Dysau were discussing earlier, there is some concern about how doxy-PEP use may affect interpretation of syphilis serologies. For chlamydia, there also doxycycline is first-line treatment. No doxy-resistant chlamydia has been described. Mycoplasma genitalium. I think this one is one that we really need to look at. Doxycycline monotherapy has a very low cure rate, around 33%. But doxycycline still has a role in sequential therapy in combination with another antibiotic based on resistance testing. It significantly reduces the bacterial load. Next slide, please. I think probably everyone's familiar with the DPEP Kenya study that randomized cisgender women on HIV PrEP to doxy-PEP or no doxy-PEP, and there was no effect on STI incidence despite high reported adherence. Next slide, please. And that's just, we can stick with this slide. There were some adherence studies presented recently that shed a little bit of light on this. So a subset of people randomized to doxy-PEP had hair samples taken. And so the 1 centimeter of hair segment from the scalp represents about 1 month of growth. And doxycycline was only detected in about 29% of total hair samples. And when you censored pregnancy time off of doxycycline, it was just around a third who actually had taken doxycycline at any point based on this. So adherence was likely an issue. I think that's kind of reminiscent of some of the early HIV PrEP studies in this population. So more studies are needed. Next slide, please. So I wanted to, kind of go, I think maybe the next 2 slides, and then I'll stop just in the interest of time. And I know we have some congenital syphilis questions that are still marinating. So, I think some of the discussion in the field, is really who should get doxy-PEP, right? How broadly should we be offering doxy-PEP? As Dr. Little mentioned, it's here to stay. People were already taking it before, we started prescribing it. So really how should we be approaching this? So, there are some who advocate for more restrictive use. This could maximize the benefit to risk ratio. It could minimize excess antibiotic use given resistance concerns. It could add to the complexity of identifying people for doxy-PEP. There are concerns about stigma and access, and there could be reduced reach or impact. People advocate for broader use, really kind of want to meet, I think, patients where they're at, and have considered stigma. There may be a greater reduction in the absolute number of STIs, but which STIs should be prioritized? Should it just be syphilis? Should it just be symptomatic STIs? Or should it vary by population? Gonorrhea and chlamydia are more of a concern for people who could become pregnant or are partners of people who could become pregnant because of the infertility concerns and pelvic inflammatory disease. And of course, broader use would involve more antibiotic use and exposure. And then you kind of have the study eligibility criteria in the middle here. Next slide, please.
It's 9:01.
Okay.
We have to, I think, stop.
Sorry. So, if we can maybe just, there's some questions to consider, which I was hoping we'd have time to.
Well, why don't
discuss,
we
but I
go
don't
to
think
that?
we will.
Is there a
Yeah.
slide?
I think it's like close to the end. Next slide, next slide, next slide. Oh, yeah, that's where the guidelines are all over the place. Next slide. Yes, well, actually, we'll skip the whole question. I really just kind of, in addition to kind of who people are providing DoxyPep to, kind of interested in, if people are tracking their DoxyPep cases or routinely collecting data, or it's just another service you provide and you're not really monitoring it in any way. Are people doing any monitoring labs like liver function tests? None are recommended in any of the guidelines, but I know that concern has been raised. How do you manage contacts to STIs who are taking DoxyPep? I think most of us would go ahead and treat someone who's exposed to syphilis, especially because of the limitations of our serologies, but especially in light of some of the more recent data about efficacy against gonorrhea. Would you treat asymptomatic contact to gonorrhea who's adherent to DoxyPep, or would you wait and test only? How many pills do you prescribe? Have you prescribed DoxyPep for cisgender women or other populations other than the study population? And kind of how do you instruct patients to take DoxyPep? You tell them to take it within 24 hours if possible, up to a dose a day, or some of the guidelines say, if you know you're going to be sexually active over the weekend, just take one dose on Monday to cover all of those actions. So practices are all over the place. There's no maybe right answer. And so just things maybe to consider, and would love for people to drop comments if you're still able to do so. I'm really interested in kind of knowing what's going on in the community, since we don't have the infrastructure really to monitor DoxyPep or track it, at the county level. So I will end there. Sorry, I know that was a lot. I always underestimate how long it'll take to go through some of this information, but hopefully you learned something, and happy to take any additional questions, and if there's time for the questions that were raised earlier.
I don't there's.
Okay, all right.
Can you just tell people about the wellness survey? Because, I just can't, you can hear me, right?
Yeah.
Sorry. I think if people want to come to talk to Winston, they should come talk or send.
My parking's good for 3 hours.
Wonderful. Or email you questions. And I think since this is recorded, you can see some of the comments that came through.
Okay.
This is just a reminder, and I want to bring up what Miley said. For UCSD health physicians, please take the time to fill out the wellness survey. Apparently, the ONNID's division has some of the lowest responses, which may reflect our wellness, but it will help us. So try to fill it out. I did it last night. It takes like 5 minutes to do. Marvin put it in the chat, so try to do it. For there's only one person I can look at here to do it. Maybe you can do it as a great, wonderful. Maybe they said that to everyone, said your division's doing poorly. But anyway, try to take care of that. And I think we'll probably, because DoxyPep is such a hot topic, I'm wondering if we have a special session on it where we have people from different groups come, and maybe you can moderate.
Yeah,
and
maybe
we can go through some of these questions.
use questions like this
because I
to
think
guide
there's
the discussion.
so much happening.
Yeah,
I will
that's
say
a-
we're gonna try to analyze our data, but it's not easy to do.
Right.
So that is something we're gonna try to do, just at least at our clinic.
Yeah, we're
But how
also
do yeah.
tracking our.
But how do you even, so for us though, how do you even define who's sexually active? We have no marker of that unless you went through every single chart. And even if you go through every single chart, it's not always obvious who's having sex. So anyway, so it's hard to know what your what the appropriate denominator will be. I can say, I think Erin Wilcott looked at this data a few months ago, and at least at the entire Owen clinic population, 5% of people had been prescribed DoxyPep, which seems like a small number, but then if you consider all the things I just said, yeah. Anyway, I said we were done, and then I kept talking. So. Thank you.
Well, yes, if there is room on the schedule for like just a town hall or roundtable discussion about DoxyPep, I'd be happy to participate and or facilitate. Sure.
We'll put Robert on it. Thank you so much. Vincent.
Thank you.